Titled our session Diabetes, Too Many Drugs, Too Many Guidelines. We thought it would be appropriate to explore the therapeutic landscape. We're focusing on type 2 diabetes, I should say here today, because the last 12 months or so have been a period of quite remarkable developments that we've been waiting a long time for, and these are clearly going to have implications for our approaches to treatment. A little bit about me, a little bit about us. I'm first and foremost a physician. Most of my professional career has been spent in the NHS as a diabetes and endocrinology specialist. Clinical research as well, and in recent years I've become more involved in aspects of new drug development. And I'm very pleased to have this year joined colleagues at the Claw Laboratory at the University of Buckingham, and because nobody knows where Buckingham is, if you can picture a mental map and draw a line between Cambridge and Oxford, that's where Buckingham is. And close by is Milton Keynes, fastest growing town in Europe possibly, and Milton Keynes is our new university hospital because we're very pleased to have opened the newest medical school in the country, opened last year, and it's actually in the not-for-profit sector. So this is an enormous, enormously important development. We'll be rebuilding our medical school, which is currently in converted accommodation. We're going to build a brand new medical school. We've got an academic centre also opening in Milton Keynes. And the medical school is really founded around the Claw Laboratory, which is celebrating its 30th anniversary this year and is a basic science and drug discovery laboratory. And for many years, through its heyday, we'll say, the Claw Laboratory was under the direction of Professor Mike Cawthorne, ex-SmithKline Beecham, who actually helped to develop what became the blockbuster drug that we all know as rosiglitazone. And the abstract of the original paper is wonderfully brief. Modifications of a metabolite produced the potent new insulin sensitizer. And of course, rosiglitazone has really become something, I suppose, an iconic drug in the history of diabetes pharmacotherapy. There's quite a story there to unpack, and my colleagues will be touching on that in a bit more detail through the sessions. Now, the realization, I think, has been over the last decade or two that type 2 diabetes is, it places our patients at particularly high risk of cardiovascular disease. That's what they die from. And so we know that glycemic control is part of the strategy to prevent vascular disease, but we realize that a multifactorial approach is required. This is the famous STENO-2 study. This is the latest follow-up data from a multifactorial intervention: glycemic control, blood pressure control, lipid management, antiplatelet drugs. Remarkably small study. I think there were 160 patients in total, but a fairly high risk of vascular complications. And although the randomized portion of the more intensive versus less intensive part of the study only lasted 8 years, you can see here the dramatic longer-term reduction in mortality, approaching 50% reduction, and cardiovascular events. And so we see glycemic control within the context of this broader assault on cardiovascular risk factors. And another important point that this slide illustrates, which I'll come back to a little bit later, is the fact that early good control of these factors has long-term beneficial effects. Now, in parallel, we've also had a series of studies which we're not going to dwell on this morning, but that they've been strategies examining how best to attain excellent glycemic control, intensive glycemic control, following the landmark UK PDS trial. Now, these have produced rather mixed results, as you'll probably be aware, with Accord, very big study, showing that actually intense glycemic control in high-risk individuals actually increase cardiovascular mortality. So there has been a kind of recalibration of thoughts about which glycemic controls we should be aiming for in particular patients. Again, we'll expand on this, but and in a sense, the focus on glucose lowering per se has perhaps been taken something of a back seat within this broader context. Now, rosiglitazone, the issues that led to the effective withdrawal of rosiglitazone in 2010, concerns about cardiovascular safety, led to the introduction of the need to demonstrate cardiovascular safety for all new diabetes drugs since about the guidance came out actually about 2008 from the FDA. So we've had these large, well-powered statistically cardiovascular outcome trials of new glucose-lowering drugs. And when this was first announced as a kind of a response to the rosiglitazone controversy, there was serious concerns that the extra expense and time that would be needed to prove cardiovascular safety would have a detrimental effect on the pipeline of new drugs coming through for the treatments of diabetes. In fact, it turns out that that concern was misplaced, and we could argue actually that these cardiovascular outcome trials have really been pivotal in generating the new data that we're going to discuss this morning, which have really taken us to a new place. So briefly, in 2013 we had trials of DPP-4 inhibitors, which we were regarding at that stage as very, very safe, well tolerated, new class of drugs. But there was a signal, a heart failure hospitalization signal with saxagliptin, not seen with the others in Examine, which was alogliptin, and TCOS a bit later on, which was sitagliptin. We had the first glucagon-like peptide 1 receptor agonist, lixisenatide CVOT reporting last year, and that showed safety, and that was fine as required. But then we had just a year ago, literally just a year ago, we had the results of a truly landscape-changing trial, the EMPA-REG outcome. And this was the culmination of a long hoped for, holy grail almost, of diabetes therapy, that in addition to lowering blood glucose, which obviously is the prerequisite, that we would actually see a reduction, a significant reduction in cardiovascular events. And we were there, we were gathered in Stockholm at the European meeting last September, and the results were presented to a packed audience. And so we saw that empagliflozin, this SGLT2 inhibitor, new class of drugs, dramatically reduced cardiovascular mortality. And this was greeted with, it was sort of jaw-dropping data, and there was a standing ovation for for these results. And things have moved on very rapidly. So we then had the LEADER study, which Bob will talk about later, with liraglutide, also showing cardiovascular benefit, and just last week, Sustain 6 with another agent in this class. So, all coming in very rapid succession, which is great. This is terrific news. But I'd like to suggest that we also need to sort of step back a little bit and think about diabetes in the real world. And this news item from the BBC website recently caught my eye because it really encapsulated a sort of fundamental issue that we have to deal with in clinical practice. Antidepressants and diabetes drugs prescriptions rise. And these are actually linked in a very meaningful way, in as much that diabetes doubles the risk of depression, and depression in some way doubles the risk of developing diabetes. And we know that the combination is bad news because depressed patients, or subclinically depressed patients, are much less likely to be adherent, compliant with their medication. Glucose lowering, hypertension, lipid disorders, and we'll come back to that a little bit later. So with that knowledge, we've got this fantastic, breakthrough pharmacotherapy. We've got the reality of translating this into the real world, and we've got no end of guidelines to help us in this task, all of which have been actually rendered pretty much obsolete by the trials that I've just mentioned. Now, the traditional approach to treatment of diabetes was sort of start with metformin. This is a simplified approach that David Matthews from the University of Oxford proposed. And then, in terms of the evidence base at the time, and then there was, we'll add something else if that isn't quite doing it, and then repeat it and so on until you run out of ideas and you use insulin. Base the choice on effectiveness, safety, tolerability, etc., etc. And that approach was really cemented, underpinned by the UK PDS. There is no getting away from UK PDS in a talk like this. And this was, of course, a trial designed to compare different strategies and glycemic targets in newly diagnosed people. And what we were told was that diabetes is type 2 diabetes is a progressive disorder. And we start pharmacotherapy with metformin, we escalate the dose, then we add something else, and then we add something else, and we're constantly chasing this inexorable upward drift, this decline in glycemic control, until the point when insulin becomes necessary. But we're re-evaluating that view in the light of proof of concept data from Roy Taylor at the University of Newcastle with his NMR machine here. And he has shown very convincingly, albeit in small numbers of patients to date, that he's shown the crucial importance of fat deposition in organs such as the liver, causing insulin resistance, and the pancreas, impairing insulin secretion. And if you can get patients to follow a strict 600 calorie or so diet, you can move the fat out of those organs, and it's only a few grams out of the pancreas, which seems to make all the difference. And the glucose levels plummet and stabilize, hepatic glucose production declines, liver fat is cleared out, and insulin secretion is increased. It increases as the fat content of the pancreas decreases. So maybe it's not such as an inevitable course that we have to follow, and we need to think about this in the context of the escalating therapy that that approach that we've been using in recent years. Now, in all of this, we're exhorted now by NICE and other guidelines to individualise the care for our patients, to adopt an approach that is tailored to the circumstances and needs of the individual, taking into account personal preferences. I mean, medication is generally unwelcome by people, comorbidities in the older patient, the patient with CVD, frailty, etc., risks from polypharmacy, and we'll come back to that. As well, in terms of the actual sort of clinical practice of diabetes medicine. So is it time to tear up the existing type 2 diabetes guidelines? Well, that's perhaps a rather dramatic solution, but I think we can say that in the last 12 months or so, we have entered a new therapeutic era, and things have changed, and there will be no going back. We'll see the guidelines evolve, no doubt. Now, to explore some of these, the aspects of drug development, implementation in real world, in the general practice experience, in hospital medicine, to help me explore these issues, very pleased to have Claire Stocker from the Claw Laboratory, Mo Tadayan, also from the Claw, our Deputy Director. Unfortunately, Stephen Lawrence, who's a GP with a special interest, can't be with us this morning because of a crisis in the surgery. So I'll be filling in for Stephen, and then Bob's going to pull it all together at the end. Bob has been has followed the implementation of new drugs very, very carefully in the real world on behalf of the Association of British Clinical Diabetologists. So, with that introduction in place, I'm going to hand over, it's a pleasure to hand over to Claire, who's going to tell us about new diabetes drugs and how we might find them and develop them.
Thank you.